Hello, welcome to the part 2 of our video. This is Anne DeGheest. This is the YouTube channel called Anne Insights. This is part 2 on where we're going to be focusing on the latest discovery we've had on how the virus is working, how the virus has mutated, and some of the information we have learned about the reopening of the country. And my objective here is to fight the virus so we can keep control of it. So as a reminder, we've broken this video into 2 pieces. The first one is epidemiology. Please go on the Anne Insight YouTube channels to get that video. And that's focusing on what's happening in the world in the US and California and Texas. And then this is the second video there. We're going to be talking about the clinical update in the reopening of America. So in this part of the video, we're going to focus on some of the long-term effects we're starting to learn about the disease. The virus has mutated and it seems to be more contagious. We'll talk about some of the lessons we're learning here on a weekly basis. We'll talk a lot about masks and how you can protect yourself. We reemphasize that it's not a question of age, it's a question of pre-existing conditions. And the young people are the carriers, and so we need to really have the young people take the responsibility of controlling the virus spread. So just as a reminder of the onset of the diseases, 30 to 50% of people don't have symptoms, or they could be pre-symptomatic. What is unique about this virus, that wasn't the case with its cousin, the SARS and the MERS, is that people are asymptomatic and being very contagious. And so that period, that incubation, is around 5 days, but it could take up to 14 days, and there has been some cases reported up to 27 days between the time people have been exposed and the time they start having symptoms. So on the average, it's 1 to 3 days. 80% of people will have mild symptoms, fatigue, and all of that. And then there's this, and then most of them will be in the lungs. And the virus attack the lungs alveoli, which is the little bags inside the lungs that transfer the oxygen. And a lot of people are having what's called hypoxia and damage with lack of oxygen to all their organ there, because there's inflammation inside the lungs, and then you don't have the transfer of the oxygen, the CO2. 14% of the people who get exposed to the virus will get severe reaction around day 7 to 10. This is what we have, what's called a cytokine storm, where your immune system over-respond. And unfortunately, you start having this cascade where the infections spread to the rest of your body and you need to be hospitalized. It is very important that you test yourself for your oxygen saturation. Go on Amazon, get a little pulse oximeter there. And really, if you're having any of the symptoms there, this is the key trigger to decide if you should go to the emergency room. 5% of people infected will end up in the ICU. And these are the people that will need oxygen ventilation, and they're going to be on serious drugs. So as a rule of thumb, it takes 3 weeks from the time we have a rise in the number of cases to the time we can start having an increase in fatality and mortality there. People who end up in the ICU can stay there up to 30 days from the time they get admitted. So this is a very long process. What do we know and what do we think we know? Because unfortunately, we're learning things on a weekly basis. What we know is that non-drug intervention works. Mass social distancing and hand washing has worked in Asia and in Europe in controlling the spread of the virus. We just need to be more diligent in the US. We also are discovering that children have a stronger immunity, but although they may have a 50% lower chances of getting sick, they are very high carriers. 79% are asymptomatic carriers. We also have discovered that around day 7 to 10, it's a very important period after you start exhibiting symptoms, that you have these cytokine storms that in a matter of hours, you have to get yourself in the hospital. So we have what's called a hypoxic, which should have the emergency room. And the oxygen saturation is between 50 to 70%, and they end up on oxygen in a matter of hours. Multiple data has confirmed that asymptomatic is between 30 to 50%. And that is unique to this disease, that there's so many people are contagious without any symptoms or spreading the virus. That's why we're having such a hard time controlling the virus. Data is showing up more and more that outdoor transmission is lower, significantly lower than indoor transmissions. And there has been some study done after the protest, because everybody was afraid there's going to be a peak after the protest in 315 cities. And it clearly shows that the combination of people being in the sun, outdoor, a lot of fresh air, and the fact that also a lot of people stay indoors because they were trying to avoid the protest, there was no peak, there was no increase of the contagion. So the break we're having right now, not related to the protest, but just to have the community spread. We're going to talk a little bit more today that this virus is also unique and it's different than other viruses, that it needs super spreading events. And these are events where you need a critical mass to have enough people there that get the disease to start spreading it. And they believe that that 10% of these events could be responsible for 80% of the transmissions. The other thing that just came out this week from a study in Georgia, that they believe that people were super spreaders, and we don't fully understand who they are yet. But those people there, instead of contaminate 2 to 5 people there, they may contaminate hundreds of people. And these super spreaders may be responsible for 2%, may be responsible for 20% of the contagion there. And so, and unfortunately, super spreaders are children and younger adults, significantly higher than older people. What we do not know yet is the timing for a mix of safe and effective vaccine. We all have hopes, but there's absolutely nothing that can confirm if it's going to come this year, next year, or ever. Or how will be the second peak of this first wave? We clearly have a peak that's accelerating. You've seen horror stories like Dr. Fauci saying 100,000. People say that's optimistic. It could be worse. We're learning that there's long-term medical effects of the COVID on recovered people, including people with very mild symptoms, not just the severe one. So we're still learning that. The antibodies, we'll talk a bit more about that. We don't know how long they're effective, and we're discovering a lot of people don't have enough antibodies immediately after they have recovered. And we don't know what the new normal will be and how long that will last. So let's look a little bit deeper. Let's go back to how COVID works. So COVID enters the cell for what's called the ACE2 receptor. And that's very important to remember, because you're going to see the ACE2 receptors is all over the body, which means it's attacking a lot of organ in the body. So you can see that using those spikes, and we'll talk more about the spikes, it finds an entry into the cell, and it literally duplicates itself and explodes. And it's not a 1-to-1 ratio. It physically grows and get out to contaminate more cells. The first system of defense is the interleukin. This is your natural immune system there in your T cells. And one of the things we're starting to do testing is to look about the antigen and how your body is responding to the exposure early in the viral load, so that we can treat people differently depending how the response is. We are discovering that there's 2 ways you can respond. Your immune system, especially for the younger population, keep those virus under control using the T cells, and they start building their own antibody to neutralize the virus as it's starting to spread. These are the people after 8 to 9 days goes back to, to a recovery there. And then you have that cytokine storm where the body, the interleukin, and all those defense system we have goes out of control and goes exponential. And these are the one, ironically, that creates all those problems we have with people end up in the hospital. So let me kind of say why that's important. Because this virus attaches to the ACE2 receptors, it attaches to every receptor in the body that has ACE2, which means it can enter a cell in 10 minutes. This is very fast. And it's 10 times, it has 10 times higher affinity to receptor than its cousin SARS, the original SARS that we had in 2003. It also attacked the endothelial cells inside the blood vessels. And that's why we have all these people having these blood clots. And unfortunately, as you know, when you have blood clots, that means it could give you pulmonary embolism, a stroke, or heart attacks. And also there are people who have had problems with their bowels that lack oxygen and had to have surgery there. So 7 to 31% of people have had cardiac injuries. That's a pretty high percentage. The blood clot is really important, because one of the things we're doing better now, after we learned from New York, is to give anti-clotting medication really early for people at high risk. The other thing that's unique about this disease is the nose. It's attacking the epithelial cells inside your nose, and that's what's damaging the nerve that goes to your brain. That's why you lose your sense of smell and taste. And that's even before you have a positive test. It's the first symptoms that you know you may have been exposed to the virus before we can even test you on the PCR test. The kidney, 78% of the patient in the ICU in New York had acute kidney injuries. And the problem with kidney injuries that, that's something that is not reversible. And hopefully they don't end up in dialysis. The gut, there has been stories there where it's attacking the gastrointestinal enterocytes and it's creating diarrhea, nausea, in certain cases, ischemic bowels. The lungs, we talked quite a bit. That was how we thought the disease was attacking the body there in that inflammatory response, which was called acute respiratory distress syndromes. And then we discovered this virus was much more than just attacking the lungs. The pancreas and gallbladder, they have not discovered people who have severe COVID, so people in the hospitals there, that they have pancreas damage, and your pancreas may have implications about diabetes. And the brain is going for the blood-brain barrier. This virus is very aggressive, and they've now started to measure that people who have had severe infection have neurological damages, and we're probably going to continue to expand on those type of studies. So a quick recapitulation there. This is a virus that pretty much attacks everything that has ACE2 receptor, which unfortunately is most of the organ in the body. And the loss of smell and taste is the unique characteristics about this virus. All the other symptoms could be due to flu and other type of disease. So this loss of smell and taste is really something to keep an eye on. So to give you an idea, this was a nurse, very good, healthy there. In a period of 6 weeks, he ended up on a ventilator, and he was a very healthy person there. What we have discovered is that 80% of people have mild to moderate cases. What we're starting to learn is that some of them have long-term problems. And they have these chronic fatigue syndromes for several weeks after they technically tested negative. Some of them in inflammatory response, and 20% of these patients end up with skin rashes, the famous COVID-2 that you may have heard about the young people there. And some of them, unfortunately, have abnormal X-rays, weeks after they've tested negative there. So we hope that these lungs will recover. And then the people who have been hospitalized, so these are people who are more serious cases there, we see some of the things I just talked about, which is cardiac injuries, congestive heart failures, ischemic strokes. Unfortunately, it's really bad. So you really don't want to be exposed. And as a result of that, we're being much more aggressive in taking care of people at home earlier and putting them on medication as opposed to waiting if they hit the cytokine storm. So the study just came out this week from New England Journal of Medicine, looking at the cases of the young children there all the way to the age of 20 years old who have developed what's called a multisystem inflammatory syndrome. And one of them is the famous COVID-2s, where you have an inflammation response. But it's not just that. Its problem is that's gastrointestinal, that's like 80%. It's you have problem neurological. I mean, this is just multi-organ in the body there. And they did a study, and on 15,000 cases that had COVID in New York, and 5% of them ended up being hospitalized. So it's not an insignificant number, much higher than we expected initially. So I want to reiterate this. The mortality and the severity of the disease is not linked to your age. It's linked to your pre-existing condition. And if you look at young people between the age of 18 to 50 years old, people who are having problem are obesity, which unfortunately is half of America, people with diabetes, people who have had COPD, chronic lung disease, or asthma. And then as we get older, a lot of us start developing cardiovascular. You can see that hypertension is a big driver there. But this disease is attacking people who already are weaker because of pre-existing condition. It's not age. CMS is confirming that. CMS look at 81,000 people that they've paid for over the age of 65, and you can really see it's hypertension. Most of these are explained by pre-existing condition there. This is good news. A study just came out that refuted the original study that went all over the press, showing that 88% of people in New York that were on a ventilator died. And it turns out this was kind of sloppy mathematics, just the way they did the calculation there. And there was a modification that was published a few days later in April, which of course was missed by the press. And if you redo the way they were looking at the data, the true mortality rate was 24%. And that's good news because, if you're really in bad shape there, we want people to put you on a ventilator if you're having problem breathing, as opposed to thinking that's a fatal outcome. So Unfortunately, that hasn't really spread in the news. So I think we need to tell people there that being on a ventilator is not a death wish. Other data has been published recently showing similar number from Emory, which was under 30% mortality rate, Vanderbilt below 30%, Palm Beach around 20%, and Mass General around 17%. So that's great news because that means that the ventilators is still a good instrument that we can use in case people are in severe distress. Fatality is higher for younger Americans, and we're trying to figure out why. If we compare the fatality rate per million there, why are we having a problem with younger people? If you compare the US, which is in dark red, and a lot of the victims are in their 50s, much more than what we saw in Europe, which were people in their 80s there. And so the belief that that's being speculated right now is because of this pre-existing condition that Americans have high obesity, hypertension, diabetes that you will have in Europe in the mix of the population. Something just came out this week that was published in Nature, and it was a study in Wuhan, and they now are following up the patient who have recovered, and they're looking at their antibodies, and they're looking to see, how much antibody they have, how long do they last. And what's a big surprise, a little bit worrisome, is 40% of the asymptomatic, the people who tested positive but didn't have big symptoms, so they had mild symptoms, and 13% were symptomatics have lost the antibodies shortly after they have recovered. That means they don't have immunity. The other thing I discovered is that the viral shedding lasts on the average 19 days. Remember, we have a quarantine of 14 days, so that may be a little bit too short. And what they're measuring was called the IgG, which you remember the IgG peaks at 21 days after exposure, and then it's supposed to last. That's the one that protects you over time. And you can see that we are trying to understand why some patients don't develop enough IgG. At 3 to 4 weeks after the exposure, where they're supposed to have recovered, we have a very high percent of people there that may not have had built enough immune system. Now, what does that mean? Does that mean they could get reinfected? We don't know. But I want just to be aware of that, that we're starting to learn that. The other thing that came out that was interesting is a study across the world looking at that age, that fatality rate. And what they've discovered is that young people between the age of 10 to 20 years old, this is again a Nature article, is 50% of them will get sick. So it's half the rate of becoming sick after you get exposed. But 79% are asymptomatic, so they are carriers. So when we say the kids, young people don't get sick, it's true, but they're still carriers. The other thing that was interesting is if you look at the people of the age of 71 years old, 30% were asymptomatic. That was surprising because typically people who are older have more pre-existing condition. So you would expect them to be more symptomatic. Let's talk about the super spreaders. This is this concept there that this is not like the flu that spreads from person to person and is a few community spread, that this virus needs a critical mass to be able to spread. And there's a study done in Georgia when they look at every person between March and May, and they look at the surveillance data. And what they find out is that when they put the shelter in place, the R naught dropped from 2.88 to less than 1, which is what you wanted to see. So that was consistent to what we see everywhere else in the world. It takes around 2 weeks after you put the shelter in place. But then they discovered that they were these super spreaders. And they've been able, by doing contact tracing and talking to people, to identify that 2% of people drove 20% of the infection. And these are typically younger people who are more infectious by 2.4x versus the elderly. So the elderly, it can be infection, but the younger people have a higher transmission rate, it seems to. So these are all information that are coming up on a weekly basis. Let's talk about what we talked last week. I just want to repeat this because it kind of ties to the prior case. Is this K factor that's coming out? And the K factor is that this virus needs a cluster of events where it reaches critical mass before it can spread. So if you're having one-on-one transmission, it's not a good way for the virus to spread. What it needs is a very high density event, typically indoor, whether it's very loud, it's crowded, poor airspace circulation there. Like the meat packing. And you can see we have a lot of states who are having problem there with meat packing infection. The infection rate is called the K, and it's measuring the need of the disease to have a cluster transmission as opposed to one-on-one transmission there. And this virus is very low. To give you an idea, the influenza in 1918 was, Spanish influenza was 1.0. The SARS of 2003 is 0.6, and this one is 0.1. And what that means is probably 10% of the cases are being spread by 10% of the people are being done. 10% of the events are basically driving 80% of the transmission there. So, and another confirmation of this data is analysis by the Chinese, who look at 318 clusters and find out that 99% of those clusters were indoor events as opposed to outdoors, where you have a better circulation. And the same thing happened in Japan, where there was a very big significance. So I think, we need to feel a little bit safer to be outdoor, but we really need to minimize all these big indoors events where people are tight with each other. Why is that? Because this virus has mutated. And let's talk a little bit about the loop. The SARS didn't have that loop. This is a little loop there, the spikes we talked about. This is the SARS 2003. And this one is much more contagious and is attacking the cell much more effectively by a factor of 10x. We talked about that in its ability to tie to the ACE2 inhibitor. This is a new graphic that just came out this week that shows that that mutation, the G614 that came out of Germany in March, has taken over the world. And it's astonishing how one mutation of this virus was able to take basically control of the spread of the virus worldwide. It is now believed that this virus is spreading significantly faster, and it's also spreading faster in the upper respiratory tract, which is your nose to sinus and your throat. So this virus is more contagious and is spreading faster. The good news is that if we use convalescent serum, even from people who were from the old mutation, it's still effective at neutralizing that virus, which makes people believe that the vaccines we're working on may still be effective even if there's this new mutation. This is to give you an idea. We shown this a few weeks ago about this G614 are really taking over the world, including the US. And it came to New York from the Europe, and then now it's starting to come all the way across the country to the Southeast and all the way back to California. So the data came up, and we talked about this week, but I want to repeat it, that this virus mutation has strengthened the spike, and the spike is what it attached into the cell, by 4 to 5 times greater, which means it could be 4 to 5 times more contagious. And the biggest issue is that the spike are much more stable. The original spike was unstable. It was having a hard time attaching to the receptors. So unfortunately, the virus is mutating in the wrong direction for us. Now, most people don't know where they get their infection. CDC just came up with this study showing that 54% of people who got tested positive when they did the contact tracing could not find out where they got it. And so therefore it reemphasized the need for social distancing and mask use, because people are getting infected and they don't know where they got infected. Of the people who knew how they got infected, 46%, they basically got it from somebody in their family. So again, go back to that indoor contamination, or from people they work with, or from a friend. So mostly it's your family with somebody that's asymptomatic. 64% were employed, so higher risk if you're working outdoor and outside in an office, as opposed to work from home. And it was driven by socioeconomics. So a lot of the people who were hospitalized were making less than $25,000 and had underlying condition. So just to give you an idea of how aggressive this virus is, when they did contact tracing for hospital in South Africa, one person, this person P1, went to the emergency room, was not admitted, just talked to a healthcare worker, was discharged, and was not even admitted to the hospital. Unfortunately, that person started spreading the virus all throughout the hospitals. Result of that one person was probably a super spreader, is 135 hospital staff were infected and 15 people. That gives you how aggressive this virus is. Another idea is that they did a test of a whole boat. What's nice about boat is that you can test everybody. And 81% of the people tested positive were asymptomatic. And that's a stunning number. And 59% of the people on the boat were tested positive. So you cannot tell who is symptomatic. And therefore, you have to take protection using mask and social distancing. Quickly go over transmission. Very important, a cough is 3,000 droplets going at 50 miles per hour. That goes really far. A sneeze is 30,000 droplets, so it's 10 times more going at 200 miles per hour. So anybody sneezing around you, you need to be careful. A breath is 50 to 5,000 droplets, so that usually fall to the ground very quickly there. And speaking or singing, also increase the velocity. And so masks do work. And just to basically reemphasize what we discussed before is the risk of infection is the function of the viral load, how sick the person is, the amount of time you get exposed to that person, and how often you saw that person. In Wuhan, when they had that second outbreak that came out, they tested 10 million people, over 90% of the population was tested, and they were able to stop it because everybody was a carrier. If you're asymptomatic, you basically spread it. If you put the mask, you stop the spread. And this was a test that came out this week. Somebody used bacteria, but it's kind of a similar way, and it shows how the droplets, if you put it in the distance in front of you, if you sneeze, you can see all the bacteria going into that plate, compared to singing, talking, and to cough. And if you have a mask, just a mask before, you can really stop the propagation. It's a visualization about how masks really are effective. Another way to look at this just came out this week. It came from the journal Physics and Fluids. They use a mannequin, and then they had a pump that was releasing a certain amount of sneeze or cough, and then they had a laser that was looking at how it spread. And we're looking at different type of face mask. So if you had nothing in front of you, it traveled 8 to 12 feet. If you use a bandana, it traveled 3 feet because it leaked from the bottom, so it's not very protective. If you had a handkerchief, it wasn't really, again, it was going straight across, still 3 feet. The cone style mask, not an N95, but the one this way, you can still there's some leakage there, but it's only 8 inches. It doesn't go very far. And if you had a stitched mask, which is a high quality there with double layers, which is the one you can probably buy online, is 2.5 inches. So that's important because that means you still have some leakage, but it doesn't go very far. So, make sure that, the bandana may be easier to wear, but it's not very protective on both directions. Again, to keep perspective there, remember what I said, the infection rate is a function of how long you get exposed and how many times. So if you're on a 6-foot side walkway from somebody else walking, it's a very low probability you're going to get infected. If you're close to a person and a person is coughing at you, and there's a lot of people coughing at you, you have a pretty higher chance. If you look at the exposure time, which is, are you talking to somebody for 3 hours? It's a working environment, versus just passing them. You can see, if somebody's breathing there, if you're just passing next to them, you're pretty much safe. But if you're in an environment there where you work with somebody there, you're significantly higher risk. That's 19%. That's a very high risk. So we don't want to get paranoid. These are very low risk if you're just talking to people, even for a long period of time, if people are not contaminated or they wear a mask. So what has been the US response to the pandemic rise? 14 states now are having a requirement to wear a mask in public. There's some issues in some state where there's a fight between the governor and some of the cities there, like in Jacksonville and Phoenix. The mayors are putting some requirement, but the state is not. There's a study just came out of Goldman Sachs that showed that if there was a federal mandate for the whole country, we could save 5% of the gross domestic product, or around $1 trillion, by slowing down the growth of case by 0.6%. And you can see our daily cases going up significantly more than that. So we absolutely need to talk to whoever you can get your hands on in your network to pass the word. We have to wear masks. We have to do social distancing. This is a study from McKinsey that showed that 72% of the states are now requiring masks. Some are required and some are recommended. There's a big difference in what people are willing to wear. There's an expectation in the study that came out that we may have to wear masks for at least 9 months. So this is not just a short period of time. Most people are more comfortable wearing cloth masks than the N95, which is hard to wear all day long. But most people are realistic to say we're here for a long haul. Another data set that came out is the younger and male are more willing to wear a mask. You can see the differentiate between the N95, the surgical mask, and the cloth mask. A lot of people are much more comfortable wearing the cloth mask. It's easier to breathe. And unfortunately, thank God it's the younger people there, because most of them are still working as opposed to the retired people there. Where we see a problem in the Northeast and the West, people are more comfortable wearing this most of the time, versus the South, where we still have some resistance. There's some cultural issue there in wearing a mask. And there's a difference between a rural area and bigger towns. So people are wearing different masks in different environments. Clearly, grocery shopping, most people now are starting to wear it. But you can see it drops down, including gyms, which is surprising because I think gyms can be a very dangerous area there. So I think we still have to educate the people what are the areas that are safe and where you may have to. Let's look a little bit about the testing. Just as a reminder, there's a period, which could be several days, where you have the viral load, which is in blue, and the viral load, as it enters the second and third week, goes down, and then you start having the infection response. So it's very hard to detect it before you have onset of symptoms. Then we can do the PCR, which is usually sent to a central lab using a nasal swab. And but you should be aware that you may have been exposed, but the PCR starts to turn negative after several weeks, after 3 weeks. That's when you have to start testing for the antibody. So just a quick reminder, we have the RT-PCR. That's the one that's been centralized that tells you if you have an active infection. That's only valid for a couple of weeks during the period of the viral load. And then afterwards, you have the antibody, which typically have to be tested around 21 days is when it starts peaking. So if you test it too early, you may have a false negative. That shows you how much antibody you have built in your body there. And now we start to also detect the antigen, which is tell you how your body is responding during the viral load. So maybe we can test a bit earlier. This is some interesting news that we have discovered that dogs can be very effective at detecting for COVID. And these are Belgium Malinois, which is a type of shepherds. And in France, they were able to have an accuracy that's pretty much the level of some of the diagnostic tests in the US. And that's because their nose is 100 million times more sensitive than the human nose. So it's something that they can smell that tells us that we are COVID positive. So hopefully we can learn something from that and maybe develop some better diagnostics. A lot of Australian country where there's a breakout right now are looking at the sewer system, and it gives you 2-week indication before there is an outbreak. And since all the sewage plants are being tested, it's something that we can easily add to kind of keep track of the spread in the US. So hopefully we're going to do that. I'm going to do a quick update just because we're running out of time today on what's going on as far as treatment. Again, as we go into the beginning of the viral load there, we are losing some antiviral. That's only for maybe the first week after you get the symptoms. So we've been investigating some of that. As the antibody start having that inflammation response there, that cytokine storm, then we're looking at some other type of drugs that can calm the immune system to bring it down, to stop the cytokine storm. This is the anti-inflammatory, the anticoagulant. And we're also looking at immune booster in that period there where you're fighting the viral load. So it's a cocktail of drugs that we're looking at. A quick reminder on vaccine, there's different type of vaccines, and we're developing a multitude of vaccines. There's over 100 vaccines that are in clinical trials in some form or shape at different stages there. Now, reality check historically, the good news is that infection disease is the high success rate in developing a vaccine. The bad news, it was only 35% of the time we're successful in developing a vaccine. I think we need a reality check, and we were all hoping to have a vaccine, and everybody's working on it. This is the massive effort that we've never seen in the biopharmaceutical industry. But you need to be aware that people are working on different mechanisms. Some is to basically stop the attachment of the virus to that ACE2 connection. Some is to stop the duplication of it. And so there's different mechanisms that people are experimenting. Quick update, we'll spend more time next week on vaccine. China has taken a modification of a prior vaccine, and they've had some success with it, and they have decided to inject it to the military armed forces. And so we'll see what happens to that. It was early phase 1 and phase 2. So it's surprising that they decide to do that because there's not enough safety data yet. So we'll see what happens there. There is a major effort in Europe between the World Health Organization, European Commission, World Bank, and the Gates Foundation to put together their resource, and they plan to raise $31 billion. And it's an amazing amount of money. Part of the money is to acquire those to share to the rest of the world, because it's important that if we just give those to the US and Mexico has it, it's going to come straight back. So we need to have a worldwide approach, and then that countries that can afford to pay for the vaccine pays for it, and that will basically help subsidize other countries. It also needs to build manufacturing capability, and we're talking to build these plants that have never been built before. So it's a massive effort. So there's huge coordination, unfortunately, outside the US. The US is not part of this, except with the help of the Gates Foundation. There's more data coming out on this MMR, and MMR is an existing vaccine that was used in the US and some of the rest of the world for measles, mumps, and rubella. And it is the rubella piece that seems to boost the immune system. And the hope is that we could probably reuse that. It's very cheap. And basically during that period of the next 12 to 18 months that we need to get targeted vaccines for SARS and COVID, that we could basically boost the immunity. And so there's a lot of research going on that there seems to be a correlation between population that have a low infection rate and a low fatality rate for people who have had the MMR exposure there. So we need to keep an eye on that. We are learning from New York that we want to delay people to be on the ventilator as quickly as we can. We want to put them on oxygen. We're starting to put them at oxygen at home with patient monitoring and oximetry. We put them on anticoagulant much earlier than before because we have these blood clots. So we're much more proactive, and that's why you see people being in hospitals but not in the ICU, which is a good thing. Quick update on the medication. I call them cocktail because there is no single bullet. We're going to use multiple drugs. This drug, dexamethasone, was discovered 2 weeks ago, and it seems to be effective for certain type of patients. These are patients who are in the hospitals on oxygen but not intubated. And we're already running out of dexamethasone, and everybody's buying it. So please don't use it at home and without a physician oversight. It's a very strong steroid. There's another drug called lenzilumab, which is intravenous, so it has to be given in the hospital setting. And that's the one that calms the cytokine storm in a way that's similar to remdesivir, except it seems to be more effective. And it's an existing drug, and it's cheaper. And it seems to basically decrease it significantly faster than remdesivir. So we'll see more what's happening there. It's a small study, small amount of patients. I was just at the Mayo Clinic. So if that continues to work, that would be great news. We'll talk more about remdesivir. The US has decided to buy all the stock and inventories of remdesivir, which a lot of Europeans say, well, fine, you can have it because we don't think it helps. So we'll see where that goes. Hydroxychloroquine. This is the story that continues to give. If you remember last week, it was withdrawn by the FDA and the World Health Organization because you had roughly 2x higher mortality in the ICU. A study just came out yesterday from Henry Ford in Detroit, and they show they have a half the mortality rate if it's given to the patient within 48 hours of being admitted to hospitals. And this is a combination with azithromycin. So again, do not take this unless you have supervision from a doctor there, because that drug has a long QT and the risk of a heart attack, if you're not careful, if you have a predisposition to it. Pretty much all the HIV medication have failed. There was another big study on the drug called Accelerator in Oxford there. We were hoping, but any of the HIV medication have been tried and they're not working there. So Gilead has been priced at $3,120 per patient for private pay. They're going to charge $520 per dose, so it's not insignificant. They claim they will save $12,000 per hospital. That is still a lot of money. And it needs to be done with multiple infusion, 2 infusions the first day and then 1 dose afterwards. So it has to be done under supervision in an ICU. There was a trial that was done, and it only works on people who are severe in the hospitals, but not on the ventilator, and people who are still on oxygen. It's clearly this period they were on oxygen, where these drugs are working to help you stay away from being on a ventilator. But they don't necessarily help for people who have been hospitalized who were not on oxygen. And if you can see, the mortality rate is an improvement, but it's not drastic. This is not a cure. The good news, they're developing an inhaled version, which may make it easier to reach to. We have to see what the price point is going to be. And again, this drug works, it stops the duplication of the virus. That's the way it's working. It's working on the RNA duplication, and it's fooling the virus when it tries to duplicate itself. Quickly on the therapeutic, again, remember the virus attached to the ACE2, so there's multiple mechanisms of action that people are working on. The majority of 45% of the compound is blocking that attachment there. If the spike doesn't go inside the cell, we can stop the duplication. And then there's a whole bunch of other attempts to basically stop the viral to continue to synthesize itself and explode and basically help the antibodies anyway. So there's multiple approach there, but the big one is to block that attachment there. This is a webinar with Werner Greene from the Buck Institute. He's a specialist in virology there. He really see a lot of clotting cascade, is the way he called it, affecting young people who can suffer devastating stroke. We think we need to share that information there because, yes, you are young, but if you have these blood clots there, you can still do damage. Also, what's interesting, they see that the virus is turning off the body interferon, which is our immune system response, and depleting the T cell. And there's a study going on at Stanford here in California where we may give an interferon injection if it tests positive to kind of boost the immune system that's being depleted by the virus. So we'll see how that works. What's interesting there is that they see a massive viral shedding that's really unique to this disease. And that's what's creating the pandemic. And then as far as the vaccine is, it's not getting the first vaccine to work. It's finding the best cocktail of vaccine and the one that works for you based on your pre-existing condition. So what we expect is that several of these vaccines hopefully will come to market, and some may be more appropriate for one person versus another. And these masks do work, and that's because we have all these asymptomatic and pre-symptomatic spreaders. In Asia, it's socially acceptable to wear a mask, and that's where they were able to control the disease where we are not. And we need some apolitical leadership across the country to help spread that word. And unfortunately, expect more pathogenic coronavirus in the coming decades. So we absolutely need to learn the lessons of what we're going through. Because as you know, there's another bat that has a virus going on right now. It hasn't come to the human yet. So we just need to learn a lesson from this pandemic. South Korea, plexiglass is the new in. Everybody's using plexiglass. I think they ran out of plexiglass capacity in the US, but people are putting in the school plexiglass to still have this sense of being in the community there, but still protecting people. So you're probably going to see a lot of plexiglass. There was a McKinsey report done with CEOs of companies to see what do they plan to do to reopen the work environment in a way that's safe. And you can see that most people are not planning to reopen until probably the end of 2020. I think Google just postponed it all the way to January of next year. So you're going to see a lot of online people working and people working from home if they can. They are trying to figure out how to protect the workplace. And so they're coming up with this protocol to increasing hygiene, offering PPE, protective equipment there, isolating people. And unfortunately, everybody's doing their own thing. And every state and every city has different regulations. So it makes it really difficult for big companies. All of them will limit gathering for both employee and customers. So we're going to have totally different interactions as we work with these companies. They're going to build separate workstations. So the whole idea of this open environment that we used to have in Silicon Valley, where you go from places to place, you don't have a dedicated space, is going to change. You may be working from home, and then maybe once in a while you go to a dedicated workstation there with physical separation. That is going to require an investment infrastructure and remodeling a lot of this workflow. This is kind of unfortunate because the only way they can measure is they're going to have temperature check when you get into the building. And we talked in the past that temperature is not a good marker. Yes, some people have a temperature, but you can have people who are asymptomatic with no temperature, people who have mild to medium symptoms who barely have any temperature. So that may give you a false sense of security, and it's probably more for legal reasons that they're doing the temperature check. 98% will encourage the use of masks. I think masks have to be accepted, and if you want to work in a public and in an office there, you're going to have to wear a mask at least until we have the vaccine. So the banks are having a problem with credit. They cannot tell who is credit worthy. Usually they could look at your track records and your spending and all of that, but everything has been turned upside down with the very high unemployment rate and the fact that people live in different environment there. So what they did, they just stopped lending. And so we have to see where that goes. They're increasing the minimum scores. They're developing new index. They're developing some type of algorithms to basically predict who may have a problem, be able to be a reliable lender. So keep an eye on that, because a lot of the American economy is working on credit, and that has usually long-term impact. So we have to see what happens. You can see it's a pretty big drop. People are comfortable sending their kids back to school. 74% responded expect safeguard at the office and all of that, but they somehow trust the school system to provide a safe environment for their kids. So this is my update for this week. Again, as a reminder, this is a part 2 of the update. Please go back to the channels called Anne Insights to see the part 1, which is a separate video that goes into the epidemiology and infection rates from the rest of the world all the way to the US and California and Texas. So again, please help me spread the word. Share to your social network. Give me a thumbs up if you like this on YouTube, and I really appreciate your support. Thank you, and see you next week.